Ladies and gentlemen, welcome at this PCR webinar on coronary physiology. It is the first of a series of 6 webinars moderated by Bernard de Bruyne and myself. The next webinars will be in August, September, October, November, and December. Today, we will talk about the basic principles of coronary pressure measurement, the practicalities, resting in the chest versus hyperemic in the chest, and the integration of the procedure in a cath lab in a smooth way. The learning objectives of this presentation can be seen in this slide. We like to understand the basis of coronary physiology and why it is important in the modern PCI era. It is an objective to understand the differences between FFR and non-hyperemic pressure ratios and how to select which one and to use it in the best possible way in a given patient, and to be aware of the need and usefulness of physiology in the diagnostic setting. My further introduction will be limited to 2 cases from the era before applied coronary physiology was customary and when FFR was not yet part of the process of decision-making. These examples will make clear the quintessence why we are here today. The first case is a male, 46 years old, a fanatic bike rider who had often chest pain during heavy exercise, but he had repeatedly negative bicycle tests and MIBI specs. He had already seen several cardiologists, and an early angiography was performed elsewhere, and he was referred to us. This is the repeat angiogram, and it shows a, let's say, non-significant 50% stenosis, tubular in the proximal LAD, in one view, and no real abnormalities in the other views. The procedure at that time was done by one of my older colleagues, Hans Bonnier, and he asked me in the cath lab and told me, can you measure that experimental FFR you have invented, and can you tell me what I have to do? So we measured FFR at that time using intravenous adenosine, and at that time you see that we had only the analog paper recordings. It is old but still beautiful, and we measured a value of 0.67. I mentioned to Hans Bonnier that this value should most likely be considered as low and most likely of indicator of ischemia. But Hans was not very surprised by the angiogram, and at that time we didn't know exactly how to interpret, and he waved it away, and he did not perform PCI and reassured the patient. 1 week later, the patient experienced sudden death during exercise testing, during a bike ride which he did. The second patient is a 45-year-old male, severely hypochondric, atypical chest pain, and negative stress testing. But after having seen a number of cardiologists, a coronary angiography was performed. And it shows this, let's say, a little bit ugly, 50% lesion at the bifurcation in the LAD, the place of the bifurcation of the diagonal branch. This time, it was Mamdou El Gamal who did the procedure, and he asked me also to test our new experimental FFR method. And if you look at the registration, again, the paper registration, you see an unambiguous, nice recording with IV adenosine, and FFR this time is 0.85. Here you have the detail at a higher speed, and also already at that time in 1994 or 1995, it was very reproducible, 0.86. Mamdou considered the lesion nevertheless as significant, and he decided to perform PCI. After he had done a balloon dilatation, stenting was not quite standard at that time, we saw a dissection. You see that there in the proximal LAD, and he decided to place a stent. But as is so often the case in this type of patients, we went from bad to worse, and you see that after stenting, there is a spiral dissection circling down along the LAD. Several more stents were placed, and at the end, the patient experienced a large enzymatic and electrocardiographically myocardial infarction. On the left hand, you see the left ventricle of this patient before the procedure, and on the right hand, a few weeks later, after the procedure. 1 year later, this patient died from untreatable heart failure. Ladies and gentlemen, most likely both patients would still have been alive if we had known in the mid-90s what we know today. The first patient would have undergone revascularization, the second would not. And although these cases are just examples, I believe that they set the stage for our discussion and the webinar today, and they give us the rationale for applying coronary physiology in the cath lab. So I'm happy now to go to Dr. Gabor Todt from GRAS for the first presentation.
Thank you, Nico. During the next few minutes, actually, I would like to share with you some aspects of the practicalities of coronary physiology. So when we talk about indication, as Nico mentioned, coronary physiology can really help you to understand WS lesions, to understand the functional relevance of WS lesions. So if we simply define that as an intermediate lesion, it's difficult to say what exactly we are talking about. But let me show you here two cases. Both cases have lesion in the circumflex, in the marginal, and we have to understand if the two patients are coming to our cath lab, then our understanding about the disease is completely different for patient 1 and patient 2, especially if the patient, like on the left side, comes with a positive non-invasive functional test located to the area where the circumflex is supplying, then I think we have not much doubt that we have two matching diagnostic test, an angiogram and the fitting non-invasive functional test relating ischemia to that territory. So we have already a clear-cut understanding and indication for revascularization. While if we consider this case on the right side, coming with no functional test before, and we identify some lesion in the circumflex without any understanding about their related ischemia, then of course we need further proof before we go on with revascularization. So if you talk about the indication of coronary physiology in the cath lab, I would like to refer to this paper from Bill Fearon from a couple of years ago, saying that coronary physiology is definitely indicated for stable coronary artery disease, especially if there is no clear culprit. And what we call clear culprit in stable coronary artery disease, I believe for me a clear culprit is if you have a lesion and a very well linked non-invasive functional test to that given territory. Otherwise, coronary physiology is a proven tool for the non-culprit lesions in acute coronary syndrome and it ST elevation infarction, but this is definitely not the tool for the culprit lesions in acute coronary syndrome. What is the principle of coronary physiology? FFR expresses actually how much the maximum flow is limited in the coronary artery as compared to its normal value, while the non-hyper indices are actually indices correlating with the limitation of coronary flow compared to its normal value. So in general, the coronary physiology indices, FFR non-hyperemic indices, they aim to express how much the flow is limited as compared to its normal value. So what is the impact of a stenosis on the blood supply of a given territory? When we talk about FFR non-hyperemic indices, they are all pressure gradient with or without hyperemia. Accordingly, the key of an accurate measurement is the accurate definition of the different pressure and of their aortic pressure. So if you want to have an accurate measurement, we have to measure very correctly what is the distal pressure and what is the pressure in aorta. For that, first of all, we need to equalize the system. If the guiding is nicely fleshed with saline, introducer is out, and we position the wire to the very tip of the guide, this is the moment when we can equalize, because this is the moment when the guiding, the pressure what we measure by the guiding and the pressure what we measure by the wire, it's exactly the same pressure, so it should be the same value. So we perform the equalization, and after that we position the wire. When we position the wire, we should keep in mind to go as distal as possible. Why is it important? If we go very distal, then we have let's say a universal understanding on the vessel-related ischemic burden, incorporated not only the visualized focal stenosis, but of course, including also all the diffuse disease what we might not see. So in this mean, if we go very distal, then we understand exactly whether this territory is ischemic or not. After positioning, if we perform FFR, we induce hyperemia, so engage the guide and induce hyperemia. Why is it very important to understand this step? Because if there is no maximum hyperemia, then we don't measure FFR. We measure something, but we don't measure FFR. How does it work? Well, if the hyperemia is insufficient, so if it's not maximal, then we actually underestimate the gradient. If we underestimate the gradient, then we overestimate the value of FFR. And if we overestimate the value of FFR, then we underestimate the disease. It might sound a bit complicated, but the principle is if the hyperemia is insufficient, then we underestimate the severity of the disease. How we induce hyperemia? With nitrate, 200 micrograms intracoronary nitrate, and either intravenous adenosine with 140 mics per kilogram per minute, or with intracoronary adenosine, what we use 200 mics in the left and around 100 micrograms in the right coronary arteries. Without going too much in the details, there are good data showing giving more adenosine doesn't really make more hyperemia. It won't be more maximal. You can reliably reach maximum hyperemia with this amount of adenosine if it reliably injected in the coronary arteries. And this is why it's important to start with engaging the guiding catheter, flushing the adenosine, and then disengaging the guiding catheter. Why do we disengage? Simply because the guiding catheter by itself, it takes some place from the left main or the right coronary artery ostium, inducing a kind of artificial stenosis there, a non-real stenosis. And of course, this is something what we don't want to measure during FFR measurement. We want to measure only the ischemic burden by the coronary arteries. So we engage the guiding catheter, flash adenosine, and this, as you can see here in these two figures, by disengaging the guiding catheter, the aortic pressure will be nicely a typical aortic pressure. This ventricularization disappears, and then what you measure there, this will be the true FFR value. So again, I'd like to emphasize, engage the guide, flash the adenosine or nitro, and disengage the guiding catheter. And after that comes the measurement of the FFR. When you measure the FFR, again, flash the adenosine with saline, or let the adenosine flashed by itself. What you normally often do, that we take a bit more in the syringe and just we flush it by itself. And then again, if the introducer was out during the equalization, do the same. Remove the introducer here again. It's very important that the setting should be exactly the same during measurement as it was during equalization. If you change the setting in terms of introducer in or out, flushed with contrast or with saline, if you change the setting, then the equalization was not valid for your measurement. So this is a key for me during the practice. Remember what was your setting during equalization and do exactly the same for the measurement. And then when we measure, you would like to see this very nice steady state phase. And this is where you position the marker and measure the FFR value. So where you see the steady state, this will be your true FFR value for the measurement. So again, and then we come to the decision making. When we make the decision, remember, you measure the FFR because you want to rely on the results. And the results come, and how you can rely on the results, this comes from the key landmark trials saying that, first of all, you cannot purely rely on angiogram. We already agreed on this, and you will see some other examples during the rest of this webinar. And you measure the FFR, and you do not revascularize functional non-significant lesions. This is why you did the measurement. You want to understand, and if you got a non-significant value, you have no reason to do revascularization. On the other hand, if you measure a significant value, this is a very good argument to perform revascularization. On the other hand, I believe that in clinical practice, we have to also understand that, as shown by Niels in this paper a couple of years ago, there is risk continuum over the spectrum of FFR and the outcome of cases with or without revascularization. We know very well from data now how lesions behave without revascularization over the spectrum of FFR. However, what we do not really have for practice is understanding the spectrum, the risk spectrum of different revascularization methods in different complexity of interventions. So this is where I would say the common clinical sense of the interventionist has to play a bit of role, that in the very narrow range around on the cutoff, we have to also understand what might be the risk of a procedure. Does it make sense to perform rotablation in a second marginal just because the FFR is 79 in an 85-year-old lady? Probably not. But on the other hand, we would perform with no question PCI in a proximal LAD in a young patient with clear symptomatic. So these were my recommendations on the practicalities. And what I would like to just emphasize for you, the indications, remember what are the indications. And second, equalize, position, hyperemia, measure, key steps of reliable FFR measurements. Thank you.
Thank you, Gabor, for this very clear presentation. We have time now for a discussion. The first question I see is a question about the disengaging of the guiding catheter. If you give IC adenosine, you have to do that quite quickly. You give the adenosine, you flush, and you have to disengage. How is that with IV adenosine? Do you also have to disengage then?
So the reasoning is quite the same. So when you have a guiding in the ostium, it takes some place, so it creates an artificial stenosis. If you use IV adenosine, then I would say you don't need to engage your guide. But it sounds ridiculous because you need to engage your guide to advance your wire. So I would say, for me, the regular practice, when you go distal with the wire, simply by pushing a bit on the wire, it will automatically disengage the guiding catheter, and then you are sure that what you measure is really the real ischemic burden of the coronary arteries and not something caused by the operator.
Thank you. There's another question. You mentioned that you have to go down as distally as you can to measure the FFR. I generally agree with that, but the question is if that is always necessary. If you are just interested in analyzing a proximal lesion, for example, should you go down completely, or is there another option?
Well, looking at this question with a very practical, I would say that if you have a focal lesion in the proximal vessel, and you have a very difficult anatomy distally, rally tortuous, smallish vessels, and so on, I would not take too much risk to go very distal, especially that by stretching these tortuous vessels, you might induce some accordion effect, causing a falsely high gradient, because it's practically a spasmus of the vessel and not the true lesion. So in this mean, I have to say I will not always go to very distal, but if you want to really understand the ischemic burden of this vessel, then your understanding will be obvious only if you are distal enough.
Thank you. There are a couple of more questions. There is one question saying, if you flush the guiding, there's the saline, does the temperature of the saline influence the pressure measurement?
It's a very good question. I would say the pressure measurement probably not. One might assume, as it was shown by the experiments of Bernard, the room temperature saline induced hyperemia. Probably one can assume that if you do a good flush of room temperature saline, it might induce some hyperemia. On the other hand, if you think that the adenosine already induced the maximum hyperemia, it won't be more maximum. So I have no proven answer, but I believe it will not change much how you flush the adenosine.
I share your opinion. There are several more questions about the hyperemia. First, do nitrates give maximum hyperemia? Second, do you ever use papaverine? And third, do you have a preference for IC versus IV adenosine? I combine
okay, so let's go one by one. Maximum hyperemia is induced by the combination of nitro and adenosine. Why? Because nitro dilates the macrovascular compartment, while adenosine or papaverine dilates or opens the microvascular compartment. So neither of the two alone induces maximum hyperemia. The combination of the two induces hyperemia, maximum hyperemia. Regarding papaverine, we are not using it in our cath lab. We are considering to use it in our cath lab. And I did some cases with papaverine while I was fellow in ILST. When using papaverine, it's considered a very reliable hyperemic agent. What one should be very careful is that papaverine, if mixed with contrast, simply by mixed with contrast in the guiding catheter, then it can induce malignant arrhythmias, simply because if I know well, there is some crystal forming of the contrast agent when it meets papaverine. So if you use papaverine, be sure that you very nicely and very reliably flush your guiding catheter to make it fully free from contrast agent, and then by giving papaverine, you can achieve a very good, reliable, and relative long-lasting hyperemia. And I forgot the last question.
Well, that was about IC and IV adenosine. But one important point in your answer now is the nitroglycerin. Nitroglycerin is standard for every coronary angiography, so implicitly also for every coronary pressure measurement. You agree?
Yes. Yeah. Especially if you enter the coronaries with any wire, then and if you want to avoid spasm, I think it's reasonable to give nitro. Regarding IV and IC, our standard is IC adenosine. It's in our lab. I would say with the pace of patients, what works very well that we work radial. We want to have a relatively quick procedures we do, and then this is why we are using almost exclusively IC adenosine.
Okay, because of the time, we have to continue. For all people who have put a question which is not answered and discussed yet, I can assure you that I will get all the questions from PCR, and we will all answer them by email to you, so don't worry. We have to continue now with the program, and the second presentation will be given by Niels Johnson from Houston about the FFR versus the non-hyperemic pressure ratios. Niels, it is a pleasure to have you here and to give you the word.
All right, thank you for the introduction, Nico. Hello, everybody. Thank you for the opportunity. These are my disclosures, nothing that's related to this. And so I wanted to start by perhaps piggybacking on a word that Gabor used a lot, and that's ischemia. And it's a word that we frequently use. I'm treating this vessel because it's ischemic. Does this patient have ischemia? And so I want to think through that notion in a few case examples. And I want to start off with this one called How Low Can You Go? And you can see this patient whom I treated, a proximal LAD lesion, angiographically moderate to severe. And you can see when I put the pressure wire down, the ratio was 0.55. And so I asked the question, is there ischemia present in this patient right now? And you might ask, well, of course, obvious, right? But let's dig into that a little bit deeper and think what we mean by that. The backstory to this patient is he's a 44-year-old man who came with no history. He developed over the past several weeks really classic symptoms of angina. When I saw him in clinic, he was a little bit hypertensive, had very mild lipids, did an ultrasound, and that showed completely a normal wall motion. I put him on a treadmill and he went for 10.5 minutes and developed angina after 6 minutes. And that's actually what then eventually stopped his exercising on the treadmill. And you can see on the left-hand side there, they developed significant ST segment depression. Now with his angiogram, the LAD lesion was something I've shown you already. The circumflex, just luminal irregularities, and the dominant right coronary artery was already sending a collateral then to the LAD. And I've shown you the physiology at baseline before. That's repeated here on the slide. And on the right-hand side, you can see with hyperemia that the value actually goes down. The FFR value was 0.34 with a very sizable gradient. And so this patient then obviously treated him, used IVUS guided procedure in order to implant a stent there. You can see the exact dimensions. And then afterwards put him back on the treadmill. He exercised for longer this time, for 12 minutes, had no angina, and also had no significant ST segment depressions. Those had completely resolved. And so I want to make the claim that this patient does not have ischemia under resting conditions. He's the example that's shown on the left-hand side of this slide. He has no symptoms at rest. He has a normal ECG. He has normal LV function at rest. And so despite this very impressive gradient down the coronary artery, there is no ischemia. And I'm showing you another example from my own practice on the right-hand side, a similar type of patient, someone who has angiographically moderate to severe lesion in the mid-LAD. Again, no symptoms at rest, normal ECG at rest, normal ventricular function, normal wall motion at rest. And actually in him, I sent off troponins and he had completely negative cardiac enzymes, despite under resting conditions, a very dramatic gradient of 0.53. And the reason that our bodies are able to do this, the reason that there's no ischemia despite these very impressive gradients in the coronary arteries, is something called autoregulation. And it's really, I think, one of the strongest arguments in favor of doing stress testing throughout cardiology, including when we're in the cath lab evaluating patients' coronary arteries. And so I want to step through what this autoregulation means and what it then has implications for in our practice. So start off, you're in a coronary artery and you're measuring the coronary pressure, say it's 110 millimeters of mercury, and you also are able to measure flow, and let's say it's at 60 milliliters per minute. Now, if you reduce the blood pressure a little bit, say you give an afterload reducing agent, the blood pressure will go down, and as a result, blood flow will drop. But that's only transient. The body figures out, all right, there's been a change. I need to bring us back to steady state, to baseline. And so you can see it moves the flow back up even though the pressure has decreased. Now, it also goes in the opposite direction. If you transiently increase blood pressure, say you give a fluid bolus or something like that, both blood pressure will go up and also coronary blood flow will go up, but only temporarily. The body figures this out, it's smart, and it says, no, I need to bring this back down to steady state. And so that's the conceptual explanation for autoregulation. On the other side of the slide now, I'm showing you some of the experimental data that supports this. You can see here that the red curve is the transient response. And again, that transient response always goes in the direction of pressure change. Higher pressure is more blood flow, lower pressure is less blood flow. But the blue steady state is the important curve. And that's the curve where, as you can see, from a wide range of blood pressures, usually between about 40 millimeters of mercury and 120 or so millimeters of mercury, coronary blood flow is kept in a stable range. That's what you might call the plateau of autoregulation. All right, so great, that's a wonderful concept, great animal data. What about humans? And it turns out that back at the beginning of the FFR journey, there were some measurements made that actually show the same effect. These were 26 patients who had normal LV function and were undergoing both resting blood flow measurements by cardiac PET, and then came to the cath lab and had coronary pressure measurements. And again, here too, you see over a wide range of distal coronary pressures, all the way from just over 40 up to about 120 millimeters of mercury, coronary blood flow normalized for mass, so milliliters per second per gram of tissue, remains constant. So what implications does this have for when we use resting metrics in the cath lab? And the first thing to mention is that there are many different ways that we can do resting physiology. This is a whole family of different metrics called non-hyperemic pressure ratios. If you take the entire cardiac cycle, that's something called rest PDPA, available on all devices, typically a threshold binary value of about 0.92. And then every manufacturer of pressure wires has come out with a sub-cycle measurement. They all have the same binary threshold value of 0.89, and you can see that they all have slightly different theoretical backgrounds or practical implementations among the various platforms, but they all do the same thing and all get you the same number for binary decision making. Interestingly enough, they all seem to have the same prognostic value. So this is some interesting data from a large collaborative effort in Asia where they took almost 900 vessels that were treated medically, and they took the tracings and sent them off to a core lab for analysis and measured all different kinds of non-hyperemic pressure ratios. And you can see that the prognostic value for 2-year vessel level events was the same among these 3 different metrics. Well, what are we to make then of the randomized trials that say that non-hyperemic pressure ratios provide equivalent clinical outcomes to doing stress testing in the cath lab using something like a fractional flow reserve? And the challenge for these trials is really twofold. The first is that what we've learned is that there's, if you just use a binary agreement, 80% match between resting metrics and adenosine. That's something that's been seen in a large number of studies as summarized on this slide. And the implications of that is that when you take a patient and you randomize them to one strategy versus the other, 80% of the time they would have gotten the same treatment regardless of which group they ended up in, because 80% of the time the 2 metrics agree with each other in binary fashion. What it means is that the place we needed to focus our attention is on the disagreements, the cases where one metric said one thing and the other one disagreed with it. That's the type of population that we need to understand, but that's not the trial design that was employed in these studies. The second major issue is that although these were called physiology trials, as you can see from digging into how many lesions underwent physiologic evaluation and how many lesions were actually treated with PCI or bypass, you can see that it was just a slim majority of lesions that underwent revascularization based on FFR assessment. There was a large amount of angiographic guided revascularization in these trials. And so for that reason, it also dilutes our ability to understand the impact of physiology when there's so much angiographic revascularization taking place. And so what I'll come back to then is this notion of when we should be using one metric versus the other. And I would say that autoregulation has really profound implications for our ability to make sound clinical decisions under resting conditions. This is a topic that we put together in a review article that came out in JACC in May. And as you can see, autoregulation means that when we measure flow, when we measure resistance, or when we measure coronary pressures at rest in patients, that is the type of situation where the body prevents us from making a link between those measurements that we're doing and clinical symptoms or pathology, because the body maintains flow over a wide range of coronary pressures, and that doesn't allow us to be causal or certain in this group, although there's certainly large group associations has been mentioned. And it's for that reason, I think, among others, that certainly over on this side, the guidelines continue to favor fractional flow reserve. It brings up that this is really remains the reference standard because it's a well-validated tool and has a much broader background of clinical outcomes. But also, I would argue, the fact that autoregulation is there under resting conditions means that we're really only able to make a link when we get rid of that with stress testing. And so if I could just summarize this trade-off in one slide about using resting measurements versus using hyperemia. Think about the patient that you see in clinic, for example, sitting in front of you, doesn't have any symptoms. You can see he's sitting there smiling as he's talking to the doc, or perhaps he's sedated on the cath lab table or something like that. At that moment, whatever you measure can't be related to the symptoms that are going on and the hemodynamics that are going on when that patient is walking or running and has angina or dyspnea or whatever it is, right? And so that ability to substitute one for the other is fundamentally limited because of autoregulation. We do stress testing in all branches of cardiology for a very good reason. And that's because when things are normal at rest, that doesn't tell us about what is or what is not happening under stress conditions. And so non-hyperemic pressure ratios, I think in my own mind, have a limited role to play given this fundamental piece of physiology that is autoregulation. All right, thank you so much for letting me go through those slides.
Thank you very much, Niels, for this very clear presentation. And as a matter of fact, there will be a number of questions on this issue. And the first question plopping up here on my screen is what the further strategy would be if your FFR and your non-hyperemic pressure ratio give a discordant result. What do you do?
Right, so there are 2 different scenarios, right? One scenario is where the resting measurement says that there's not much gradient, but yet when you give hyperemia, there's a very big gradient, right? That's the opposite of the kind of case that I showed. And there I think we have to ask the question, well, what do you think is causing the patient's symptoms, right? The patient's not having symptoms when he or she is just sitting there relaxed on the cath lab table. And so I would argue that the stress measurements in that case let you understand what's probably happening when the patient is out walking or doing stairs or whatever activity it is where the patient began to have symptoms. And so I think therefore the hyperemic measurements are the ones that you're able to then link with symptoms. On the flip side, you're of course going to have some cases where there's a resting gradient, but it really doesn't change that much with hyperemia. And so the FFR values end up being greater than 80. And I like your case example that you had at the very beginning that started off this session, Nico, right? We have so much data that's shown us that when the FFR values are negative, patients do just fine with medical therapy. You don't need to treat them. And in fact, you can save a lot of complications and such when you just treat them medically.
Yeah, where my own experience is that in particular, in younger patients with proximal lesions and large arteries, you can quite commonly meet a low pressure gradient at rest, which increases quite a bit at hyperemia. So these are the patients where you can meet false negative NHPRs. There is another question asking why there are different recommendations between the European and the US guidelines. I presume it is not so easy for you to answer.
That's difficult. I'm not certain why guideline recommendations are made the way that they are. All I can say is that the data and the physiology hold no matter which country you live in. It's not that autoregulation is only something that happens in one country but not the other. I think that it's something I can only say that the autoregulation is just a fundamental tenet of physiology, and that's something that holds regardless whose guidelines you're reading.
Thank you. There is another question here, but that's not related to your talk, maybe remotely. It asks about dipyridamole. You are very familiar with that also because of your non-invasive stress tests. And the question is, can you use it for FFR measurement?
Right, it's a fantastic question. And actually, if you go back to some of the work that Bob Wilson did around 1990 when he was beginning to develop medications like adenosine and other vasodilator medicines, actually several of those studies used dipyridamole for making intracoronary measurements of coronary flow. And the reason just pragmatically that we don't use it in the cath lab is that the dipyridamole requires a 4-minute infusion, and then it requires another 4 minutes before peak hyperemia takes effect, right? And so if you think it's painful to stand there in the cath lab for a minute or two while IV adenosine is running, just try standing there in the cath lab while you give 8 minutes of dipyridamole before it kicks in all the way. The other drawback is that the hyperemic effect from dipyridamole is very long lasting. And so as a result, if you're wanting to make serial measurements in multiple vessels, or you want to do it before and after PCI, it just makes it practically a little bit more cumbersome. And so that's the drawback to dipyridamole, is its long time of onset.
Thank you, Niels. There is one more point. It says the question, IFR is based upon the assumption that a wave-free period exists where resistance is minimal. Can you comment on that assumption?
It's a great question, and it goes back to some of the development of what happened with IFR. And if you look at the subsequent publications from the group in London and others, what they clearly found is that resistance during the wave-free period is not equal to the resistance that we see during hyperemia. There was a nice study called IDEAL that came out in the European Heart Journal, and it showed very clearly that the resistance continues to decrease when you give full vasodilator drugs like adenosine, for example. And so this notion that simply by looking at a small portion of the cardiac cycle at rest, you're somehow able to see through to what happens during hyperemia is something that was hypothesized at the beginning, but later overturned by data from that same group. So that fundamental theoretic underpinning of IFR is something that has not panned out.
Thank you, Niels. There are at least 10 more questions about the hyperemia, but we do not have time to discuss them all. And I will answer all of these questions separately by email, so don't worry about that. Because of the time, we have to turn now to Sergio Batista from Portugal for the third presentation. Sergio, the floor is yours.
Thank you, Nico. So I can have my slides. It is my role now to convince you of FFR as being the natural prolongation of the majority of coronary angiographies. And you were talking about guidelines. Well, the European guidelines clearly state that you should not revascularized lesions if they are not ischemic lesions, and that can be either by a non-invasive test or by an invasive test, either FFR or IFR in our guidelines. And actually, the thing is that in your daily work, in your cath labs, most of your patients, as I will show you, will not have this information. This is some work we did a few years ago with unstable patients that were referred for suspicions of coronary artery disease, almost 5,000 patients. And we looked at the information we had when they arrived in the cath lab. And as you can see, the vast majority at that time only had a treadmill stress test, and only around 33% of the patients had documented and localized ischemia. And if your cath lab is like mine, well, these are only one quarter of the patients, because the vast majority of the patients we treat are ACS patients. And in those patients, around half of those patients will have non-corporate lesions, which you really need to test to know if you need to treat them. So in summary, most patients at the cath lab don't have information about ischemia, and only a small minority has information about localizing ischemia. And recently we looked at this again, and over the years until 2017, we have some changes. There are more patients doing CT scans, but still there is a large majority of patients that arrive to the cath lab without information. And as you know, the more recent guidelines in stable coronary artery disease, European ones, state that in low and very low likelihood patients for coronary obstructive heart disease, CT scan should be the first test to do. And on the other side of the interval, patients with very high risk should go directly for invasive angiography. So using these guidelines, what we will have is even more patients that will arrive to the cath lab without any information on ischemia. And so this leads us to the concept of the angiography as an all-in-one procedure. In the same procedure, you can define the treatment strategy for all your lesions, and that avoids additional ambulatory ischemia tests. And it's particularly important for patients with stable coronary artery disease, in those that don't have any ischemia tests, in those that only have a treadmill stress test, patients with only a coronary CT scan, with equivocal imaging ischemia tests, or patients with multivessel or multi-lesions disease. Also in patients with ACS, non-NST ACS, and intermediate non-corporate lesions, as we have seen in the first presentation, also it can be performed, the measurement of FFR can be performed in the same procedure, and it's reliable, and you can make decisions based on those measurements. And finally, in patients with ST, elevation myocardial infarction, in selected cases, you can also perform perform an FFR measurement of a non-corporate lesion and decide based on that measurement. Now, the second group of patients I would like to talk to you about is patients with microvascular disease. And we tend to think about microvascular disease as a different entity as compared to macrovascular disease, although probably that's not true, and it's only a different presentation of the same disease. It has the same risk factors and eventually the same clinic. And why is it important? Well, basically it's important because it's highly prevalent, and you can see that on this slide. It summarizes a few studies in which roughly half of patients in which this was tested showed some form of microvascular disease. The same here in this American large registry, in which almost 45% of patients with ischemia and a positive test didn't have any obstructive coronary artery disease. The second reason is because it's associated with a worse prognosis, and we can clearly see this in this slide, in this study in which coronary flow reserve, CFR, was measured in patients, and patients with a low CFR, in this study it was defined as below 2.32, they had a clearly worse prognosis as compared to patients with a normal CFR. And the same in this second study, here in brown, you can see the curve of patients with microvascular disease, and their prognosis was as bad as prognosis of patients with obstructive coronary artery disease and diabetes. And the third reason why it's important, it's because nowadays we can actually clarify its mechanism. And we have several tools that allows us to measure the microvascular system. And these two are based on pressure wire measurements, coronary flow reserve and the index of microvascular resistance. The later one is measuring only the micro circulation, and those two allows us to define if the patient has microvascular angina. This is an example from our center in a lady. This lady had a positive imaging test and angina, and she had normal coronary arteries with no obstructions, and as you can see, she had a very low CFR, 1.1, and a high IMR, and so this suggests that she has microvascular angina. We also can, in the cath lab, measure, do some provocation tests with acetylcholine and try to see if there is a vasospasm, as you can see in this slide, on the upper part, spasm of the left coronary artery, and down you can see a spasm of the right coronary artery. And this is important because using these three tools, you can define different groups of patients with different etiologies for their symptoms. So you can have either patients with vasospastic angina or patients with microvascular angina. And the treatments they will do will be different, and the results, if you tailor your treatment to the different mechanisms, are also different, as shown in the Carmichael trial, in which patients with a tailored treatment had a much better quality of life. And there are several trials ongoing trying to also demonstrate reduction in events in these patients. This is clearly a second reason for doing physiology tests in the cath lab, and in this context of all-in-one procedure, you can also, in patients with angina and non-invasive tests, which are positives, but that don't have coronary obstructive disease, you can diagnose microvascular disease. And finally, the third groups of patients in which you will need a pressure wire are the ones in which you want to guide the PCI itself. So nowadays, you can use both the pressure wire to decide if you need to revascularize a lesion, but you can also use it to plan the way you are treating the lesion. You can do it by doing pullbacks and co-registration that will help you to decide where to put the stand and the stand size. And at the end, you can even evaluate if the procedure was successful. And this is the final group of indications for using PCI in the cath lab, PCI planning and evaluation of success. And so in summary, my take-home messages are these. Most patients with suspected coronary artery disease don't have information about ischemia. Pressure wire-based indexes will allow the definition in the same procedure of the treatment strategy of all lesions. It will also allow you in the same procedure to evaluate the mechanism of angina if they have ischemia and no obstructive coronary artery disease. And finally, you will be able to plan your PCI and to evaluate its success at the end. And that's it. Thank you, Nico.
Thank you, Sergio, for this nice overview. That brought up several questions. Some of them in the beginning were, how often do you encounter microvascular disease? I believe that you answered that already in one of your slides. It will be somewhere in 25 to 50% of the patients. And then the next question is, if you have a patient with almost normal coronary arteries and typical angina, you are suspicious of microvascular disease. But if you have a patient on the table with, let's say, significant epicardial disease, how can you suspect that there will also be additional microvascular disease? Is there a way to do that? How do you attack that point in your own cath lab?
Well, actually, if you have very, very severe disease, well, there are some studies in the beginning of IMR showing that there is an independence of IMR measurements independently of the presence of epicardial disease. Actually, if you have a very, very, very tight lesion, probably there will be some effect. But you can always decide and treat the lesion which is significant, and then you can measure afterwards IMR and CFR in that patient, and then define if there is also some microvascular disease. And there is some evidence that in some patients which will get to a normal FFR after PCI, if they have a low CFR at the end of the PCI, their prognosis is worse as compared to patients in which you get at the end both a normal FFR and a normal CFR.
Thank you. Then there is another point. You mentioned the acetylcholine test. And acetylcholine tests are done in patients who are really suspected for microvascular disease. And in these patients, quite often you do multiple other tests, FFR and IMR CFR, or what else. If you do an acetylcholine test, do you that at the beginning of the procedure or at the end? Do you do it before the other procedures or afterwards? What is the best strategy for that? Because, of course, you are influencing the normal physiology quite a bit.
Yeah, you're right. Actually, in my country, in Portugal, it was only recently that acetylcholine was approved for being used in coronary patients. And so we have, our experience is quite small at this point. But I would say you should do it at the end after waiting a few minutes after you have tested IMR and CFR. I don't know if the other operators have more experience on the subject.
And if you do acetylcholine testing, how do you do it? You do it most likely with consecutive steps. And do you give the acetylcholine as an infusion, or do you give it as boluses?
You give it as boluses, and you do it by steps. So you start with a very small concentration, and then you increase it until the upper one, which is 200. And you do it by an injection, a slow injection, around 2 to 3 minutes. And you, during the injection, you keep an eye both on patient symptoms and on ECG in order to see if there is ischemia. And at the end of each injection, you do an angiography to see if there is vasospasm in the coronary arteries.
Okay, thank you. Then there is another question about the CORMICA trial. You mentioned it. CORMICA trial was very nicely performed. The question is, what is the best practical consequence of it? The CORMICA trial was quite observative, I would say. And the question is, what is the practical consequence of the CORMICA trial?
Well, I think they are very important because now you can, if you use that approach to studying all patients with a suspicion of microvascular disease, at the end of the procedure, you can tell the patient either you don't have at all disease, neither obstructive disease, neither microvascular disease. And that's important for a patient to know that he does not have any disease, or you can tell him, well, the most likely mechanism for your disease is this one, and so based on that we will choose this medication, this treatment. And it was nicely shown that when you do that, patients improve, they get better, they have less symptoms, they have a better quality of life. So I really think it's important. I would personally like to know what's the mechanism of my disease if I had symptoms. I think that's important for the patient.
Okay, then there are several questions related to a new methodology for microvascular assessment, measuring absolute flow and resistance. I think that also Gabor and Niels can say something about that. And I do not know if you have in your cath lab at Portugal experience with these absolute flow measurements.
Well, I did 2 cases a long time ago with a previous catheter, but not with the new one, so I don't have any further experience.
Is there anybody else of the speakers who like to comment on that? Gabor, you have experience or not?
Not in Graz. In Graz, we do not have, unfortunately, the device, so we did not have the chance to test it here. The experience comes from the times when we worked together on the development of the catheter with you and with Bernard.
Okay, we will then postpone these questions because the number 6 of the webinars, the one in December, will be fully dedicated to microvascular disease and the assessment of microvascular disease. And this will also be one of the topics. And for the persons who put a question on this topic, again, I will answer it separately. Okay, thank you very much. Are there other questions or other points of discussions you like to discuss? Maybe one of the speakers who still want to add a little bit on what we have said so far? If that is not the case, I think that we are going to the wrap-up. I will try to get my slides back. There we are. Okay. In the first place, I think that we learned today that there is incontrovertible evidence that physiology guidance of PCI improves the PCI outcome. There are lower event rates in terms of MACE, revascularization, MI, and DES, and that's definitely the case in stable angina, and most likely also in acute coronary syndromes. Is there underutilization of FFR? Well, definitely there is, but it will not be that much as often suggested. Gabor already mentioned that you do not need to measure FFR in every case. if a patient has typical angina, a positive stress test, 1 severe stenosis on the angiogram, then 1 + 1 + 1 is 3, and we need to do a PCI, and we do not need to measure FFR. Also, in acute STEMI, that has been discussed by the speakers, most often the ECG guides you in selecting the culprit lesion. But in many other cases, ambiguous lesions, let's say between 30 and 90%, note the number of 90 defined by Sergio, and multivessel disease, non-culprits in ACS, or post-PCI functional assessment, physiological evaluation is indispensable. Gabor has taught us that the techniques in itself are easy, not very difficult, and he has extended about the principles and the practicalities. Of course, some basic knowledge on coronary physiology is mandatory. You need to be aware of some pitfalls, and some troubleshooting is also mandatory. But I would say that a dedicated interventionalist can master the principles and techniques in coronary physiology within, let's say, 20 to 30 procedures. Then there is the issue of FFR versus non-hyperemic NHS. That has been discussed by Niels, and personally, I would like to add a couple of slides to that discussion. In this slide, you see the 2-year mortality and the defined flare study. These data have never been published, but they were merged in the publication with the 2-year follow-up data of the Sweetheart study, and thereby the high mortality in the IFR group was obscured. What you see here is the high mortality with IFR, even in absolute terms, about 4% after 2 years, and that is exactly twice as high as in the FFR guided group. And in addition, you can notice that the 2-year follow-up with IFR and the low-risk defined flare study is as high as the mortality in the angio-guided group in the FAME study with complex multivessel disease. It is up to all of you yourself whether you take a few minutes of extra time and the infusion of a harmless drug, adenosine, to calculate your FFR, or whether you are satisfied with the non-hyperemic index. But realize what you are doing and be aware that the accuracy of the resting NHS at the best equals about 80% of the accuracy of FFR. That there are many false negatives at least 50 to 20% and a high mortality with IFR and a 2-year follow-up of defined flare. And be aware that the European guidelines do not differentiate between FFR and NHPR. So if you leave out hyperemia, you're not violating the European guidelines. You are violating the ACC guidelines, which have been revised and state now that FFR cannot simply be replaced by IFR or other resting NHS. And finally, as we have seen by the presentation of Sergio Baptista, in the modern catheterization laboratory, all of these physiologic techniques, not only FFR and NHPR, but also IMR and in the future absolute flow and microvascular resistance measurements should be available and applied smoothly, and as a potential extension of regular coronary angiography that should be used for planning of the strategy for understanding the mechanism of ischemia and evaluation of PCI. The latter point we have not discussed extensively. It is, of course, an issue of interest. What conclusions can you draw from FFR after PCI? When should you conclude if it is successful or not? But that will also be the topic of one of the future seminars. So, having come at the end here, I would like to thank all of you, also on behalf of PCR, of Abbott, who was the sponsor of this webinar, Professor De Bruyne, my co-moderator, and all the speakers. And we hope to see you back at the next 5 webinars in this series in the months August through December. And again, I will answer all questions separately. The list will be sent to me by PCR. And if there are still additional questions, please send them to us by email. So I would like to conclude here and thank you all for your participation. Have a nice evening.
Thank you. Goodbye.